Video 4, Pelvic Assessment. Although assessing the pelvis as a whole is not going to change the treatment approach, attaining a level and balanced pelvis, at least sitting, after treatment, and ideally between treatments, is an indicator of success. However, the most important indicator of success, i.e. symptom resolution, is joint clearance during treatment and lesion progression between treatments, but we'll come on to that later. A thorough assessment of the pelvis should involve visual and palpatory assessment, standing, sitting and supine, and involve the relative positions of the posterior superior iliac spine and anterior superior iliac spines and iliac crests. It should also involve the assessment of leg length. However, this is not generally necessary at consultation unless there is a glaring difference. If after a few sessions the symptoms have not resolved, this may be necessary to determine if there is a true leg length discrepancy or some other pelvic anomaly. When the patient is standing, kneel down so your eyes are at the same level as the pelvis. Place your thumbs under the PSISs. Try to keep them horizontal and flat against the skin. Palpate the area with a broad contact and then make a mental note of their relative position. Then, using the second ray of each hand, assess the level of the iliac crests. Make a note of your findings. Now, with the patient seated, repeat the same procedure and make a note of your findings once again. To make a fuller assessment, we can of course check the ASISs, standing or supine, but for the moment this is generally sufficient. The pelvis may be level, but more often than not there will be some degree of torsion or tilt. Generally, the pelvis will appear torsioned when the PSISs are not level and where the lower PSIS is accompanied by a higher iliac crest and the higher PSIS is accompanied by a lower iliac crest. This may seem counterintuitive, but due to the shape of the ilium, as it rotates posteriorly, the PSIS drops, but the anterior aspect of the ilium rises. Conversely, as the PSIS rises, the anterior aspect of the iliac crest drops. The most common torsion is a posteriorized left innominate and anteriorized right innominate. If both the PSIS and the iliac crest are lower on one side, the pelvis is generally tilted to that side. At the end of each treatment, the pelvis should be level, at least when sitting. If it's not level standing as well, we may consider a true leg length discrepancy. If after a few sessions the pelvis and lumbar spine are clear but symptoms have not resolved, a more thorough assessment of the pelvis sitting and standing, as well as leg length assessment, should be undertaken. When assessing the pelvis, there are 5 main patterns. The pelvis may be level, or it may be torsioned, with the left innominate posteriorized and the right one anteriorized, or torsioned with the left anteriorized and the right posteriorized. The pelvis may be tilted to the right, and the pelvis may be tilted to the left. Once the pelvis is clear, true leg length is more easily determined. With the patient lying supine, get the patient to raise their bottom and wiggle it from side to side. Once they're lying flat again, check to see that the ASISs are level. Make sure the body and legs are straight, and now check the relative position of the medial malleoli. I find this is more accurately assessed by eye than with tape. As my thumbs are 2 centimeters wide, it's relatively easy to determine if there's a significant leg length discrepancy. A difference of 1.5 centimeters or 3/4 of my thumb width may benefit from a heel lift as a correction.